Good afternoon, all. I'm Adam Myers, co-director of the Health and the Public Interest MS program at Georgetown University. I co-direct this program with Adrian Fu Berman, who is on travel abroad today, and I don't think she's going to make it. Um, it's I'm going to start out by telling you a little bit about the program. As I said, it's a one-year program to from August to the end of July, roughly, and it's a program that emphasizes social determinants of health along with influence of really all non-medical factors on health and healthcare. And today we have a great seminar lined up. I'm excited to hear our speaker. He'll be introduced momentarily by Francis. But I just want to say we have a lot of things on our schedule over the years about women's reproductive health and all of the things related to that. So it's great to get a little broader viewpoint today. So the way the seminar is going to run, Francis is going to give a short introduction after I'm done, and then the speaker will be talking for about 40 to 45 minutes. It's up to him how much he wants to stop and engage folks. The chat's a good way if you want to do that, Dr. Shattuck, or you can ask people to on mic as well. Um, After Dr. Shattuck is done, Francis will then take over moderating the discussion session, first students and then outside participants. And we have up to 1:15, but we don't have to use all that time. So, Francis, it's your floor.
Hello, my name is Frances DeCleva, and I'm really excited to introduce our seminar speaker today. Dr. Shattuck is a cutting-edge researcher on public health topics, including masculinity, gender, reproductive health, COVID-19, and HIV. He has led groundbreaking studies and implementation projects that engage men and women, couples, and adolescents around their reproductive health and has pioneered programmatic content based on this expertise. Dr. Shattuck has implemented the first trial of male engagement in reproductive health in Malawi, scaled up vasectomy services nationally in Rwanda, and designed the first efficacy study of a mobile application as a family planning method, known as the DOT study. A community psychologist, Dr. Shattuck's approach emphasizes the use of mixed methods research that triangulates the perspectives of providers, beneficiaries, and policymakers. His multifaceted work reflects the real-world applied projects, including the development of the first mobile games promoting reproductive health, and partnered with Meta during the pandemic to disseminate real-time data of more than 55 million responses through the COVID behaviors dashboard. Also, until it was upended by the executive order in January, Dr. Shattuck was a co-chair of the USAID-sponsored Male Engagement Task Force, which convened men's health stakeholders from around the world to share cutting-edge research and best practices. He's currently looking for a new home for that community. And a fun fact about Dominick Shattuck, Dr. Dominick Shattuck, is that he gets anxious if he goes more than 2 months without watching an episode of Curb Your Enthusiasm. So without further ado, it's my pleasure to introduce you. Take it
All
away.
right. Thank you so much. I really appreciate being here today. And I'm kind of about a week into like having not seen any Curb episodes, so you might see some jitters. We'll see. Um, and I'm going to cover a lot of topics today. I appreciate everyone showing up, but my bunch of different topics. It's not super data heavy, this presentation. And I'm going to start us off with a question. Okay. So this question provides a little bit of foundation for our talk. So please respond by either typing yes or no into the chat. And the question is, has a medical professional ever talked to you about family planning or contraception? Now, I'm not talking about STIs or HIV. This is strictly about family planning and contraception. Okay, so let's see, if you don't mind, if you're willing to share, uh, please share a little bit about this in your experience. Okay. I'm seeing a lot of yeses, and I'm going to assume some gender identity here, and seeing a lot of female yeses, some no's, and and a couple of no's from men. And I raise this question, and I use this question a lot in my different presentations around men's reproductive health. And the responses are pretty much always the same. Every woman in the room pretty much raises her hand to say, yes, I've had this conversation with my provider around reproductive health and family planning. Yet you'll usually get one or two men who've had and raise their hand and say that they've had that conversation. And I'm not embarrassed to say that, like, I'm very forthcoming about my own personal experiences, and you'll hear a few of them today. But that the first time a doctor ever talked to me about reproductive health, I was 40 years old. I had two children, and I was literally sitting in my vasectomy pre-op visit that I had scheduled with the provider. Okay. And at the time, I was actually running that Rwanda vasectomy scale-up project we're going to talk about in a few minutes. So when it comes to reproductive health, men's experiences at the doctor's office are significantly different from those of women. So whether a woman goes into the doctor's office because she twisted her ankle or she has a headache, at some point they're going to be asked this kind of battery of questions, right? That include things like, are you sexually active? When was your last period? Are you using a family planning method? Which one are you using? And I'm sure there are 10 other questions that kind of follow those up. And some of the women in the room may be familiar with those and may have experiences of those themselves. Well, for men, nothing like that ever happens in the doctor's office. If it does, it's a very unique situation. So, what this kind of implies and the implications of health professionals not engaging men in this context, really kind of fails to share accurate information, kind of takes one channel of public health kind of contact and influence out of the game. It provides opportunities for misinformation. And it also kind of misses that opportunity for the doctors to kind of say, hey, you're sexually active, here's a handful of condoms. Take these on your way out of the office. Or, kind of so your wife is using an IUD and maybe she's having troubles. Maybe he could normalize that kind of conversation around some of the side effects that come with using contraceptive methods so that he's better prepared to be a partner for his wife later on. It also fails to normalize these conversations about reproductive health with men and their friends. So if he doesn't have the right information, if no one's ever had a conversation with him about this, how does he then communicate that to the men in his life? It also kind of reinforces this. This is the big one, that men's responsibilities. These doctors are people we look up to, we oftentimes trust, and we look to for critical information about keeping ourselves healthy. So it reinforces this notion that men's responsibilities associated with preventing pregnancy, planning a pregnancy, supporting your partner through challenges of pregnancy and childbirth, and possibly even being a great parent, it kind of fails to reinforce those messages and instead kind of leaves a big gap, right? It's so in my mind, the way I view this is that it solidifies the reality that all these are women's burdens to carry. One of my roles up until recently was I was co-chair for the Male Engagement Task Force. And this was a USAID sponsored activity. So this is a vibrant community of about 600 individuals in dozens of countries. The members are researchers and advocates for men's health programming. And currently, as mentioned earlier, I'm looking for ways to kind of reestablish this space. The task force uses this conceptualization of engaging men in sexual and reproductive health programming. We view men as clients or direct recipients of healthcare services. We view them as supportive partners, and we also view them as agents of change in their communities or even in their home and in their family. So the graphic comes from work done by a woman named Meg Green and some other people. And the examples I'll share will articulate these roles kind of in full. The most popular document we created through the Male Engagement Task Force is called the Do's and Don'ts for Engaging Men and Boys in Programming. Designed for program researchers and implementers, the tool provides some practical implementation guidelines. And if we take a look at this first bullet, things like do recognize and meet men's distinct needs. Every man and his context are different. This may seem like common sense to us, right? And that all men are not the same. This is kind of a no-brainer in some ways. But this is particularly important to remind people when we consider the vast majority of sexual and reproductive health programming focuses on women and focuses on women's outcomes. So when we do have the chance to kind of bring men into this conversation, bring men into this situation where they're being engaged for reproductive health outcomes, we've got to make sure we're doing our due diligence around the research and around the work. So when we think about that Venn diagram from the previous slide, this tool also recognizes that gender equity should be at the center of reproductive health programming. And efforts to this point must be made and grounded in the local context. Okay. Slide. All right. One last document I wanted to share is a brief we published last year. The Building Bridges document or brief focuses on the role of relationships within the lives of men and boys. It articulates the link between quality and longevity of relationships and health outcomes. And I'll touch on some of those dynamics a little bit later on in the talk. And I've shared these two documents and some others with the hosts, and they can email them to you all afterward. So I'm going to quickly review a few projects and contextualize how a portion of the male engagement programming is implemented globally. So we want to remember that Venn diagram, right? So we're going back to that the first intervention describes men as supportive partners and also another group of men who are motivators, who are the actual agents of change, right? So the Malawi Male Motivators Project took place in the Mangochi district of Malawi, which is at the very bottom of Lake Malawi. Really beautiful place, a little bit dusty, but very beautiful place. Where we were working with Save the Children on this project, and we learned that they're having some challenges engaging young women, young married women in the district. Most of the women were in intergenerational marriages, which means that their husbands were 10 or more years older than them. Which kind of, as you can imagine, shifts some power dynamics and makes it a little bit challenging to have meaningful conversations. And the Save the Children staff had identified a moderately high need for family planning in the community. And they also noticed that many of the women were having their children back to back or within 2 years without proper spacing. And if you're familiar with this literature, you know that spacing children is important for women's health and the baby's health and the overall family's health, really. So last it was clear that the women were not talking about family planning with their husbands. Working with the SAVE staff, we realized the best way to reach these women was through their husbands themselves and working with the husbands directly. So as a result, we developed an intervention and evaluation. The intervention consisted of 5 one-on-one visits with a trained motivator who were men in the community that were leaders in the community, but they were also men whose wives were using family planning. Vasectomy services weren't really a service in that part of Malawi at the time. Now it is. The design of the intervention was built on some previous interventions that were done by Equimundo, or previously known as Promundo, in a project that was called Stepping Stones in South Africa and Southern Africa, African countries. You can see the outline of the curriculum here, and the first and second sessions were really focused on making the pitch for using family planning services. You can see I highlighted the information shared around the benefits of birth spacing and information around the different contraceptive methods and where you can get them. Then in session 2, the motivator talks about his use of family planning, kind of providing himself as a model that's central. It's a central component of male engagement activities. When working with men, the messenger is also as important as the message itself. All right. And in session 3, the motivator then works with the participant to practice role play and kind of work through some activities to get them to practice using the words and the language around reproductive health that may be foreign to them in their other conversations they've had with men or other people in their lives. And then at the end, they kind of check back in, try to resolve any questions. Sometimes they even talk to the women, to the wives of the participants. Our evaluation found that family planning uptake increased in the intervention arm and the control arm because these were small communities. Contamination of the control arm was very possible. We didn't really measure that so much, but we kind of assumed it because many of these men were in collectives and they were farming collectives, and they were in situations where they were being social with other men in the community. And when you get a visit in a space like this by somebody like a motivator, people are paying attention and possibly asking questions. So the central driver of family planning use was the men's reported change in communication with their partners, and then particularly as it related to the ease and the frequency through which they were able to talk about reproductive health and family planning. So we were able to do a qualitative follow-up study, and this really validated the findings. The qualitative data provided insights about how men's newly developed communication skills facilitated the conversations. It also provided, that ability. We all know, like, sensitive conversations are hard for anyone, right? So during the sessions, the motivators discussed initiating conversations through the role plays, through the debunking of myths and misinformation that were held by some of the men. And they practiced this new language and facilitated that conversation that then facilitated the conversation with their wives. Yet more importantly than the men's feedback was the women's, right? And you can see that in one of the other documents I shared that will be shared with you later on, where the women's were saying things like, I felt like I was included in the decision making after the intervention, or they said, like, I felt like he was actually listening to me. So this is transformational change, right? And we all know how hard relationships can be, but improving these couples' interactions with one another in such positive ways can be impactful, not just for this aspect of their life, but for other aspects of their lives as well. So kind of working with the men, providing them with the language, kind of normalizing the conversation around reproductive health, and encouraging them and helping them to have the conversation with their partners was an effective way in which to intervene and kind of build the skill sets related to reproductive health and using contraception. So shifting gears a little bit to Rwanda several years later, and referring back to that Venn diagram, this project is primarily focused on men as a sexual and reproductive health client, right? So bringing men into a clinic to receive a service. This project focused on a very specific type of vasectomy, procedure, which is called no scalpel vasectomy with thermal cautery and fascial interposition. It may seem like a mouthful. They pull it out, they cut it, they burn it, they sew it off, and they push it back in. It happens in on both sides, it happens in less than 10 minutes. And I saw guys walk home after, or ride that, even a couple guys rode their bike, but that wasn't advised by any means. So the service was integrated in collaboration with the Ministry of Health, who we designed a cascade training system that was established to develop several master trainers who would then in turn train other providers in their community, in different communities around the country. This resulted in at least one trained vasectomy provider in all the district hospitals, others situated in less central centers or central communities, and several who performed outreach services beyond their immediate town. So we kind of had main hubs and then smaller health facilities, and then some people who went out from the main hubs into the rural communities. So please note that 2,500 vasectomies may seem like a small number in a country with 11 million people, but it's not. Because remember, the country of Rwanda continues to have about 1,000 vasectomies performed annually. And you don't really, or you shouldn't be counseled to, vasectomy is a permanent contraceptive method. It can be reversed, but only in some circumstances. But because it's not reversible in most cases, the value of vasectomy grows with each new client. You're kind of building that. You're building that what they call contraceptive years, a couple years of protection. Okay. And so there's no method switching usually when it comes to vasectomy. So I wanted to share some of the feedback we got from the clients and their wives. So one of the things I couldn't find the graphic for this specific piece of information I'm going to start talking about. I apologize for that. But one of the things we did was we compared the responses of the vasectomy clients on a survey question about gender equity with a question by using a question that's in the DHS. And the DHS is a national survey in most developing countries that talks about a number of different topics, including reproductive health. So when we use the gender equity questions with the Rwandan vasectomy clients, their scores were much higher. They had much more gender equitable norms than the general community or the country of Rwanda, the people in the survey. And so I share this because I want to highlight message the reason number 3 on the left that's bolded. So side effects of other female-controlled hormonal methods. Now, what this implies is that the men who got the vasectomies had more equitable beliefs. But if they're reporting to us that 50% of them are reporting that one of the reasons was because their wife was using a hormonal method and she had side effects, this makes them very different than those the Malawi couples, right? These couples were having conversations about reproductive health. They were talking about the challenges that she faced, and they were kind of making decisions together in that context. So these guys were, and you can laugh at this, but they were in some ways low-hanging fruit, right, for vasectomy. But the thing is that they are definitely showing they're a different client in terms when it comes to reproductive health services. So and then he actually did something, and he actually took action. And when we actually, I don't know if I have it in this slide deck, but the main way in which they learned about vasectomy services was actually through their wives. And in Rwanda at the time, women had to consent for their husband to get a vasectomy, and they had to have 2 kids. There's a lot of rules that were similar to what it was in the United States in the 60s and 70s, but it now changed. So Rwandan vasectomy clients in 2012 looked like most vasectomy clients around the world. They were older, they had 2 or more kids, they were married, and most of their partners had used a different family planning method in the past. Also, they were at a point where hopefully, and obviously, they all didn't want to have any more children, right? So for most people, discussing medical procedures is a private matter. You heard me talk about my vasectomy in the very first slide. Well, when we asked the Rwandan couples if they ever talked about the vasectomy procedure with their friends and family, most of them said no. And we need to find ways, when we think about a method like this, we need to find ways to normalize it and to provide that kind of messenger that we talked about earlier in the presentation. So now I'm going to shift to like some really new research. It's not my research, but it's something I want to share with you I think it's really important that you're aware of when it comes to vasectomy. All right. So, and I'm a little bit obsessed with this topic right now. So you might find this interesting. I hope so. Like I said, I'm obsessed with this whole space right now. It's really interesting. So right now we're seeing some major shifts in demographics associated with vasectomy uptake in the United States. The next slide will show how these shifts were impacted since the Dobbs ruling. But this slide, we can see here that the increases were actually happening before the Dobbs ruling. So these are data from 2014 to 2021. And you all are familiar with the Dobbs ruling about abortion access and provision of abortion in the United States. So before that ruling came out, the trends when we were seeing greatest relative change was in men who had no children, who were single, and who were young. Like these are young men, 18 to 34 are young men, right? And so this is a trend that we were seeing even before the Dobbs ruling. Since the Dobbs ruling, immediately following the Dobbs ruling, we saw a huge demand for vasectomy in the United States. It increased significantly, right? And this wasn't only in one part of the country. Although there's data that suggests that demand was higher in states that were banning abortion and that were suggesting that they were going to ban abortion, but it was all over the entire country. And I realize this is a pretty busy slide, but the message is that the trend in vasectomy clients, they are getting younger, they're getting more single, and they're increasingly likely to be opting out of parenting altogether. Okay, as a public health professional, my concern isn't that they are making this decision in the sense of like they have the choice to make this decision. That's not my primary concern. My primary concern is that they have accurate information, they know the ramifications, and the likelihood that this will probably not be able to be reversed. Okay, so what's also important about this slide is that I've been compiling data, and the next time I give this talk, I will have a next slide that's actually going to be women who are young and unmarried without children who are getting tubal ligations, because the percentages might even be greater than those related to vasectomy for young men. All right. All right. So I'm going to move away from reproductive health for a minute, and I'm going to focus on men's health in general for a minute or two. I hope it's all right with everybody. All right. So you're probably familiar with these statistics, right? These are CDC stats. I have the years here as well. Men's life expectancy, deaths by homicide, and cancer rates are higher than those of women. So let's be clear, these indicators need to be improved for everybody, but we can see kind of the discrepancy here, right? And then again, men and women are struggling with respiratory diseases and diabetes, and we're hearing about interventions, but you know, figuring out how to make men and women more healthy. And one of the ways in which, as a community psychologist, as somebody who focuses on behavior change, one of the things I focus on is risk behaviors, right? And so when we look at risk behaviors, you can see that for men, they're more likely to be regular drinkers. They smoke more. They use illicit drugs more. They drive faster. They take risks that many women don't take, right? And so where do those risks come from, right? So when we talk about, I do a Google search on men's health, and you're gonna get at some point you're gonna bump directly into this magazine, right? You might even be seeing these images right away. So you're going to get some version of this picture. So landing on this magazine is actually kind of fitting because in many ways, like Men's Health magazine perpetuates the norms driving those risk behaviors, right? So I'm going to ask you to take a minute and, when you think of me, you may have already been studying this in your classes, but what are some of the masculine norms that you think about that might that are present in our society that our society places on men? Let's kind of put a few of those norms into the chat, if you don't mind. Okay, breadwinner, being strong, strength, competition, being competitive, right? Sometimes we hear a lot about like things like stoicism, not showing any emotion, right? Not being empathic or showing the physical strength, aggression, emotional stoicism, right? Resilient, great. Pain resistant, right? All right. So that's important. And thank you for playing along. I appreciate it. And this is there are a number of different traits that we look at and with traditional masculine norms. And the question for me as a community psychologist is around, how do these norms impact men's health? So before we go further, I want to provide a couple of definitions. And that masculinity is enacting all those things we think about as being a man, right? So masculine norms influence men's behaviors. And men endorse these masculine ideals when their masculinity feels threatened. One of the theories that I find really interesting in this space, if you're not already aware of it, is the theory of precarious manhood, which suggests that, you know, manhood is something that will make sense. I kind of really I enjoy this name, but it's really reality that manhood must be maintained. Rather, I got a little mixed up, but reality that manhood must be maintained. Being a man is simply not enough, right? So you better act it out all of the time. Men's behaviors are policed by other men, and teasing and bullying and social isolation, and those are three types of ways in which many possible outcomes associated with reinforcing those standards of masculinity. So studies have identified the relationship between traditional masculine ideologies and poor health outcomes among men. Men who endorse these beliefs, so those traditional masculine beliefs, are less likely, more likely to avoid preventative screenings. They're oftentimes more likely to not have primary care providers. They're more likely to miss appointments and to refuse psychological care, and have a higher medical mistrust. And also, they become increasingly socially isolated as they mature. Sometimes we know that money matters and that politicians and the attention of our society nobody really responds until we start looking at the associated costs of this medical avoidance. And men's avoidance of medical care, whether it's self-imposed or structurally imposed, costs our society a lot of money. These statistics are from one of my colleagues at Hopkins, Roland Thorpe, who focuses on men's health disparities or health disparities in general, but in particular, men of African American men and Latino men's health disparities. So you may have seen the Surgeon General's report on loneliness, which links loneliness to numerous negative health outcomes. So it's an issue for men and women. And as we get older, our social networks shift, and research shows they typically contract and get smaller. This reality is compounded for men. This dynamic is described in depth in the Building Bridges document that's going to be shared with you, and in work by people like Naomi Way and Judy Chu, and many others. And they talk about men are somewhat conditioned to become increasingly isolated as they mature, and they adhere to some of these more masculine traits, traditionally masculine traits. So what they're really lacking is the ability to be emotionally intimate with others. Right? I saw somebody had put something like that on the slide, on the feedback in the chat. So for many men, being competent and self-efficacious in intimate settings is a large hill to climb, right? For most people, but particularly men, it's uncomfortable sharing problems and secrets. Men's health researchers suggest that women speak to one another face to face, while men speak to each other shoulder to shoulder, like Roy and Ted Lasso in this picture. Managing the negative aspects of masculinity and facing life challenges come down to having a very strong social support network, right? And the strength of your network is dependent on your ability to be intimate with other people, to find that safe space with the people in your life. So in the Malawi Male Motivators Project, it was about helping men find the words to express their issues and interests. We use games and activities to facilitate the development of the skill set, and we help shift them from their typical roles. And in Rwanda, the vasectomy clients in many ways were that low-hanging fruit, as I had mentioned before, and they were already talking with their wives. What they needed was a structural intervention that gave access to reproductive health services. So for other men, maybe in those Rwandan communities, they need both the structural intervention and other social interventions that kind of help them to build the skills that those guys in Malawi also were building. So skills related to communication and empathy are necessary to transform the behaviors of men. Aspects of these interventions need to be embedded within programs across the larger public health agenda. Okay, so now I don't know how much time I have left. I want to be careful. All right. This next section of slides I've never talked through before, so it's a very personal kind of experience. It's not data here. It's just my own kind of investigation in this space as I kind of build out this work a little bit more. As you know, public health is kind of about pushing messages over media platforms, and our control of those platforms is limited, and it gets more and more limited as the number of channels and opportunities to share information gets greater every day, right? With social media platforms, with the podcasts, with new networks and things like that people are sharing information across. So you've probably already heard about the manosphere, right? And this is an informal network of communities that are focused on men's issues, right? Masculinity, gender relations, talking about like men's problems in a way. And this includes a wide range of perspectives. So from self-improvement and men's rights advocacy to more extreme and controversial ideologies, you know, they're all there. And I'm sharing my experience engaging with just a tiny fraction of this, of the less extreme side of the manosphere. And so just to kind of talk this through, and then maybe I've been reading and learning a lot from younger people in my life, whether they're students or other people as well. But I don't want to speak for them, I'll speak for my own exposure. So, professionally during COVID, I was busier in the first 2 years of COVID than I had ever been in my life. So I was trapped in this same basement office that I'm sitting in right now. And I was working on large data dissemination project with Meta. And I was actually also, while I had my regular job, which was also upside down. So it was like super crazy busy. And like everyone else, my kids were kind of in school, just on the other side of this wall right here. I decided that my main exercise at that time was going to be walking the dog and through my neighborhood. And so over a couple of years, I walked this same 3.2 mile loop almost 350 times. Okay. And over those 350 times, many of those times I was listening to podcasts while I was making that trip around the neighborhood. So I did. I listened to Joe Rogan periodically, and I still listen to Joe Rogan periodically. One of the key shows that I found really fascinating as a men's health researcher was a conversation about microplastics and sperm counts. Right, this woman, Dr. Shayna Swan, was the guest, and she described her research on these topics and shared her social media survey, which was called, or still is, you can find it on Instagram, called the Jizz Quiz. So this was a super engaging conversation. It was detailed, it was research oriented, and she had some actions and some, suggestions about how to avoid the plastics in your life and things like that. It made sense to me. And so over the next couple of years, I continued to drop in on the Rogan shows. I didn't listen to all of them by a long shot, but I also would drop in if he had somebody I thought would be interesting. And as I kind of listened and watched, and sometime I'd watch it on YouTube, or I would, have it on in the background while I was doing something. What I started to hear was that we're moving from this conversational podcast to really a space of human optimization. And it sounds a little bit hokey, but I'll try to explain. So in 2014, there was this, as far as commencement speeches go, I knew about this commencement speech. I don't know why. I think it got kind of passed around on the internet for a while. But Admiral William McRaven had had given a commencement speech at University of Texas, where he was, which is his alma mater. So the speech became a little bit famous. You can find it on YouTube. You can get the transcript at 50 different places if you look it up. So in there, he talks about specifically how Navy SEAL teams, uses the example of Navy SEAL teams and how making your bed can help you write the passage of your personal ship, and when you're having difficult times, right? So what he's actually saying, it's really good advice, right? So psychologists say this to their clients oftentimes, like build up enough small wins that you are in effect moving in a positive direction, and continue to hold, and build on those wins, and just kind of continue to tick the boxes, and you've done positive things, and reflect on it, and understand the positive things that you've done. When you pull the transcript or you watch the video, you realize it's a good speech, and it's relevant to a lot of people, right? Especially people who are in the doldrums of life. And it's good because it doesn't just talk about the small wins, but he also integrates interpersonal engagement and pro-social behavior into his message. This includes asking for help, appreciating others around you, embracing chaos, and taking risks and jumping into things. All right? It's not just about making your bed. But what we find out is that other people like Jordan Peterson took this message to the extreme, and they kind of lobbed off the pro-social behaviors. So when I first heard Jordan Peterson's talk about this, he left out all those pro-social behaviors. He emphasized the tasks and de-emphasized the social connections. Peterson sold many men and many other podcasters. As he got more notoriety and more attention, they realized that this was a viable message to kind of continue to build on. As far as my perspective on this, now I haven't watched everybody on the internet by a long shot, but remember those tasks, those masculine traits we listed earlier, the accomplishments, completing tasks. It resonates with everybody, especially men and boys. Once you get those tasks, once you know what those tasks are going to be for you that day, whether it's lifting weights or it's making your bed or it's cleaning out your car, they become purpose-driven action. They're tasks that are low risk. They allow you to retain control of your life. They allow you to do them independently. They're easily transferable to things you already know, like athletics and strength and toughness and stoicism. And all of these things are traits of those traditional masculine norms. And in and of themselves, the discipline, the adherence, and becoming more physically fit, kind of going to having a cleaner room. There is nothing wrong with those things. But when they are optimized or taken to an extreme, when they start to become trouble, right? So yes, definitely follow through the tasks, improve your day, get the wins, but also find the social connection, which is an additional risk that you're going to take to improve your life. When we go back and we compare Jordan Peterson's message and any of these podcasters' messages with Admiral McCraven's messages, the former Navy SEAL makes a point to include those pro-social actions that are typically squeezed out of men and boys as they mature. The world of podcast hosts, in turn, kind of took this make your bed approach into what I'm calling this human optimization. And here's a couple of podcast titles. And I know a title is to kind of catch your eye and get you to listen. I get that. But these are just a few that I was able to pull very quickly, right? So we all love a good title. Peak Performance, Unlock Your Full Potential Through Science. Mastering Sleep. I didn't know sleep was something you needed to master, but I appreciate it in a way. It's a key to longevity and productivity. Fueling Greatness. Okay, optimizing nutrition for energy and focus. And, when I took these titles, and I had a list of about 20 of them actually, when I took the titles and I threw them into ChatGPT, this is the image that ChatGPT kicked out, right? So you have this mainframe computer that is going to show us what we're going to become later on, right? So I love asking ChatGPT to do things like this. I think it's really fun and interesting. But this is what you get when you start throwing in these titles that these people are kind of pushing you towards. So this human optimization. But what's interesting about this is that within the podcast themselves, remember we were talking about intimacy. Woven into these podcasts are these moments of deep connection and vulnerability. So this is an episode of Theo Von's this past weekend from about 2 months ago. He's one of my favorites, right? So he's hosting this person you may know. His name is Richard Reeves. He's at the American Institute for Men and Boys. He's one of the biggest advocates for men's health that's out there. He's got kind of the biggest microphone at this point in time. And so definitely check out the whole episode. You'll learn more about men and boys' health and well-being. But there are great moments and lots of good information in here. And the clip that I'm going to show you is a great reflection of some of these intimate moments that happen on these podcasts. So Theo Von, if you don't know who he is, he's a comedian, and he is a recovering addict who shares his experiences openly with the audience. I can only imagine the impact that his kind of sharing and his talking about going to AA meetings and things like this have on some of his listeners. So in this clip, what we see Theo talk about his brother who modeled a very pro-social behavior. At the same time, he's acknowledging the value of that pro-social behavior and that interaction with his brother. And then he also models this engagement with Richard Reeves, right? Who I'm betting they didn't know each other long before this episode was recorded. And I follow Richard Reeves pretty closely because he has that big microphone in this space right now. And this is probably the best interview that he does on any of those social media platforms or platforms, I guess is the thing I should say, is that, he tells more personal stories in this interview. He shares more about his family, his history coming from England, his family as coal miners, things. It's a very good and compelling interview because it's very intimate, right? And most importantly here, Theo is modeling vulnerability by sharing his story with millions of listeners, right? This guy, he interviewed Trump. He also interviewed Bernie Sanders. He has a humongous platform. And the thing is that within this kind of kind of tension between the manosphere and this dynamics, there are these moments of this pro-social behavior and this intimacy that I think a lot of people, including me, tune in for because it might not be a big portion of our lives in real life, as we say, right? So all right, that's my kind of musing on this. The last slide I have for you guys is kind of like a little breakdown of some of the people that I pay attention to in this space that are focused on men, or not all focused on men, but they're male podcasts and kind of appeal to the male audience, I think, more than female audiences. And as I mentioned, I do listen to and tune into Joe Rogan now and again. He's a pretty good interviewer, and he's curious. He thinks he's providing an alternative perspective on things. It's not really that alternative. You go sit in a bar in DC for 35 minutes and somebody's going to tell you the same thing. But the thing is that he likes MMA. He's an MMA expert. And I don't know anything about aliens, but I love listening to people talk about aliens. And at some point in every show, he breaks down to aliens and he just can't get away from it, which I find fascinating. Then you have comedians that kind of provide you with like pushing the envelope of the jokes, which may be offensive at moments, but at other times they're talking, they're just trying their things out. And also they do have their imperfections and they show you some intimate moments. You have these next three, Jocko, the manliness, and the Huberman. These are much more kind of polished interviews and produced sessions that Huberman is one of those people who you listen to him, he like memorizes these literature reviews and they're different every week. And like this guy's brain is ridiculous. But you don't get as much of the emotional side and kind of interaction, but much more of like the kind of business that appeals to a lot of men. And then also these two guys in the middle are the who I think are the best. And this is Chris Williamson and Stephen Bartlett. They both happen to be British, and they are both thoughtful interviewers. They show sincere appreciation for their guests, and they really do a nice job of kind of getting to some of the details about some of the details related to the topics. I will say a lot of times when I buy new books, I buy them because they've interviewed somebody who's written the book. The others on the right hand side, Prof G, you may know, and then Smartlist is a show where you have a lot, especially during COVID, you had a lot of kind of emotional interaction between the three hosts. And then on the far right, you have The Imperfects, which is an Australian podcast where they do a nice job with an Australian psychologist. And then Now and Men is very academic. But I wanted to share that. I don't know how unique my perspective is on any of this stuff, but I find it very interesting. I'm hoping to expand my research into this space a little bit more and see where it takes me. So I appreciate you having me here today, and I look forward to any questions people might have about the information I shared. Thanks.
Thank you so much, Dr. Shattuck. That was not only entertaining, but incredibly important. I'm so grateful we all got to learn from you today. I guess we're going to open it up for questions now. So typically we let the HAPI students go first, and then we open the floor up to anybody else. Just to get things started, I was really curious. I understand that when someone opts into getting a vasectomy, obviously the ideal position to make that decision is from you do not want to have children anymore. So I'm curious what the primary determinant, though, is for a vasectomy to be reversible or not.
So I'm going to tell you, there's probably other people who can speak better to this than me, who are physicians and who are actually urologists providing the services. But I think a lot of it has to do with just what kind of vasectomy you got in the beginning. If you have something like thermal cautery fascial interposition, remember you're talking about a tube that connects from one another. And what's also important about that tube, about the vas deferens, is that it's a number of tubes that are kind of one inside of the other inside of the other. And so they have to make sure those things are connected correctly. And if there's not enough space within that tube, then you have a challenge, right? So maybe not long enough, but maybe it's the quality of the tube itself. The vas deferens itself might not be of quality to reconnect it. There are other ways, if you've had a vasectomy, to have a pregnancy that deal with extracting the sperm from the testicles. And then doing like artificial insemination, that kind of thing too. But that's definitely, it's an interesting question. I never thought I would get into this space of work and research, but it's super interesting and it's great for going to a party and talking about it too. So yeah.
Great, thank you. Katie, go ahead.
Hi, this is more of a like methods question, but when talking about the Malawi intervention that you did, you said that you didn't measure contamination between the control and intervention
Yeah.
populations. And I was just wondering how you would measure contamination in this case and
Yeah.
like what you consider that to look like.
Well, you'd ask the people in the control arm or in the intervention arm, you'd ask them questions about who they socialized with, right? And who they may have talked to in the community, or if they talked to anybody in the community um, about the intervention, the information they were learning, things like that. That would be when you're trying to control for contamination. And contaminations is a big issue with social interventions like this, especially in a community that's pretty well knit, closely knit, and people, you know, most men in the community may convene at one local point in the community on a regular basis. So yeah, it is very possible. And we realized and kind of even hoped a little bit that that would happen, so long as the information is actually accurate, right? So yeah, it's a good question. Yeah, Hannah, I think you have a question.
Hi. In one of the documents that you provided us about vasectomies in low resource settings,
Yeah.
it had talked about negative attitudes among providers being a significant contributor to low uptake of vasectomy services. So
Mhm.
I was wondering if you could just elaborate a little bit on that and
Yeah.
how you think this should be addressed.
Yeah, one of the challenges we were seeing in the clinics where we were working, like Rwanda, it wasn't so much Rwanda's a different place, right? So Rwanda's much different than other locations in sub-Saharan Africa because there is kind of this collective, there's a different pride in Rwanda than and a different kind of level of expectation when you provide government services. Anybody who's worked in, you may recognize that. Some people may think I'm crazy, I don't know. But they many times in clinics, providers are working with women all day long. And when the one guy shows up, he's not prepared. The provider is not then ready to have the conversation with, he's seen 65 women that day. And number 66 is a man who's come in for some reproductive health service. And he's the provider, whether it's a him or a her, or a counselor or a nurse, um, may not be prepared to actually have the conversation with this guy. And the other challenge could be that the man isn't ready to actually have that conversation, even though he knows he's coming in for something that he wants, right? So he's underinformed. He's not ready to make a decision about a vasectomy. But oftentimes we're seeing that these providers need to be trained. They need to have interventions that are focused on their preparation to work with men in clinical settings. There's been a few papers come out recently from Australia. This guy, Zach Seidler, and there's another one, Gallus, I think that is the last name. And they're talking about gendered care and gendered care that's related to um, kind of working with providers around what it means to provide, whether it's reproductive health service, really they're focusing more on psychological services, clinical psychology. And so how do you work with a provider, whether it's a psychologist or a medical provider, to engage with men not in such a top-down method, but more in like okay, this is the problem. We're going to meet at this problem together, and it's kind of a little, I won't say trickery, but kind of working the language with the client, where you're saying, you know, we're going to come and make our decisions together. We're going to look at all the information together. A lot of men are more receptive to this kind of teamwork approach than they are from the let's listen to the expert and implement that what they're telling me about my health and what I need to do next. So there are efforts to kind of put this into place. There were some work around this in the past, but now I think it's much more sophisticated and thoughtful because of all the work around gender norms and gender equity that has happened around the world. So we're seeing that a little bit different now. But it's a good question. And you can't really blame the providers either because they're seeing 65 women in a day and they've got to kind of get into them, get their work done. I mean, it's nobody's fault. It's just kind of let's figure out how to do it the right way and do it equitably for everybody. Yeah. Thanks. Yeah, CJ.
Hi, yeah, thank you for this. I was just wondering if you could elaborate a bit more about why young and single men are getting more vasectomies and kind of why that rate is tending or trending upwards.
Yeah, honestly, nobody knows. So the thing is that I put in for funding to kind of is specifically research this, specifically in the DMV area, if you're in this space. Um, and the thing is that some of the anecdotal information is saying that, okay, there's a great book called Generations, and I'm looking at my bookshelf. This woman named Jean Twenge, Twenge, and she has written this book. She's a demographer, and she talks about like kind of generational differences and hitting markers and things like this in your life. And what we're noticing is that Gen Z is really late to a lot of these markers, whether it's first kiss, first sex, first drink, first drugs, whatever, right? And she attributes this to parenting, right? So she's saying that a lot of this goes back to the way in which um, Gen Z has been parented by my generation, my kids, like this kind of stuff. Much more involved. Our expectations for our kids and our relationships with our kids are much different. So this kind of changes the way in which the children are starting to see themselves, and how do they see themselves as parents? What's the messages that they're receiving as a young person around being a parent? Is it worthwhile? Is it something that they feel is a good investment in their time and money? Because this is really what we're talking about, is like, you know, do you view parenting as something that's fulfilling and something that you want as part of your life? Or is it something that it might happen, but I'm not really crazy for it? Or some people had bad experiences with their relationships with their parents and things like this, or they heard negative things about having children and stuff like that. And they kind of embrace that a little bit more. And I also feel like some of this is tied into some of the other anecdotal information is tied into um, young people's outlook on the world, right? So hearing messages around climate change, hearing messages around the political dynamics and equity and challenges in our society, we're hearing that some of those things are motivators for young people to not opt into having children later in life, and basically opting out of having children later in their life. Which again, this is a choice, and I'm not here to say do this, do that. I'm not perpetuating the cat lady dynamic like in the last election, right? So really, this is about a choice and making sure people are informed, and that, if you don't have the resources to kind of support you. I mean, this is a difficult decision, and kids are a big commitment, and they add some amazing things to your life. It ain't easy, but they do add a lot of amazing things to your life. So yeah, it's a good. I think you need to ask this question to your friends. I think you need to ask this question in your class, and I think you need to ask this question, when you're hanging out with your buddies, shooting hoops, or like kicking around, listening to music, whatever it is. Just say this crazy guy was talking at our class, and he said this, and like, this is, what do you guys think of that? Because you need to have the conversation. Talking about intimacy, that's an intimate conversation, right? And how many times, I actually push it back on you. Sorry, CJ, I don't mean to call you up, but if you're willing, how many times have you ever talked about having kids with your buddies?
A handful, probably counted on one hand.
Probably on two fingers. So I'm you the exact same as me. Honestly, it never came up, right? Or if it came up, we kind of like, oh yeah, kids, blah blah blah. Let's go get wings, like Travis Kelce said in that video, right? Those are the intimate conversations. That builds relationships. Those are the friendships. Sometimes your buddies don't want to have those conversations, but push them a little bit, push them into that space, you know, and you women who have male friends, push them into that space and tell them they need to talk to their buddies about this. They're gonna look at you like you're crazy, but it's okay. That's okay. Yeah. Thanks, CJ. Benjamin.
Thanks for the talk. Really appreciate it. Um, so I've seen at least I've read sources that say, there was a sharp uptick in male vasectomies as well as female reproductive um, health choices post, obviously, the reversal of Roe v. Wade, and also as more abortion rights become restricted. My question for you is, at least when it comes to male vasectomy and male health, as you know, many of them are irreversible, and we're seeing more young men getting vasectomies. Do you expect there to be like uh, regret associated with that decision? I mean, I've read sources that say, most men don't regret the decision, but generally the regret is associated to change in like relationship status or age of vasectomy. And that's something that we're going to see as a problem, 10, probably 10, 15 years from now.
That's a great question. And it's a question I have too. I don't know if they're going to show more regret. Logically, you would imagine the proportion of people with vasectomy regret would go up because they're younger and just the numbers work like that in a logical format. One of the things that, and you're absolutely right, that is what the literature says. People who get vasectomies are less likely to feel regret. And one of the things I wonder sometimes is it because they're men and they're saying like, I don't regret nothing I did, all that kind of thing? Is it more machismo? I don't know. But the question is about what are some of the alternatives? One of the things that I've been fortunate to get involved in this space is there's a growing number of what we call novel reversible male contraceptive methods that are in development. Okay. If you want to learn more about this, you guys and gals and people in here today, you can go to a site that's called the Male Contraceptive Initiative, okay, .org or MCI. And they're based out of North Carolina, and they fund they're a foundation that kind of funds um, reproductive health programming for men that is around like new methods. And so there are several new methods that are in development. Right now, there's a trial in Australia, and this is getting to the regret question, I think. There's a trial in Australia around this what's called a vasal blocker. And it's basically a substance they put into the vas deferens, like you saw the cauterization, so it would be like blocking the vas. And then when the person says, okay, now I want to be a dad, they put another thing into that vas, and it basically um, it reverses and breaks down the substance that's in the tubes into the vas, and they shoot it out of their with their ejaculate when they have an orgasm. Now, that's a vasal blocker. There are also some hormonal gels that they put. People will rub them on their shoulders, and those stop sperm production or stop what is actually sperm motility. The idea that how well the sperm swims, which really impacts their efficacy in pregnancy. Um, but there are several different methods that are kind of in different stages of development. Nothing's coming out in the next couple of years, but in 3 or 4 years, it's possible that one of these methods would come out. They're actually trialing some other thing, a different type of vasal blocker right now in a few different countries as well. So that might, one of the questions is around regret is would some of these novel male contraceptive methods actually have a very viable market of these young men who really want to postpone pregnancy, maybe block it altogether, but just in case in the back of their mind, maybe someday my mind's going to change related to parenting. Is that the space where these novel male contraceptive methods fill in the market? So that's actually stuff I'm going to be hosting in April. I'm going to host a panel of experts on a webinar. So you follow me on LinkedIn. I'll post it at some point. You can come and listen in on these experts. Richard Reeves is actually one of the experts who's going to speak during this event and talk about like what are the implications of putting these things into the market. Because when we talk about that reproductive health conversation in the beginning, what if there are methods for men that are actually viable methods that I'm going to use for a long period of time or what have you? That changes the dynamic in the clinical space. It changes the dynamic in the interpersonal space between, husbands and wives and partners and dating. How does that change your dating relationship? Where is the trust? Like, what are the trust implications to all of that? right? All this time that's been put on the woman to kind of hold the contraceptives responsibility. Once these things come on the market, that changes it quite a bit. And maybe for the good, but maybe not. And a lot of people are going to have to figure out how to renegotiate that relationship. And that's a big social change. And it's a big, behavior change dynamic. So yeah, it's a good question. It's kind of, who knows? I hope they're not regretting it, but or if they do, they have a lot of money so they can go pay, because insurance is probably not going to pay for a reversal, and they can find the right guy to get it. We'll see. Yeah, thanks. All right.
And the floor is open to anybody to ask questions at the time. But just, oh yeah, Quentin, go ahead.
Hi, thanks. I'm curious about sort of the pro-social behavior you were talking about towards the end. So I work with this organization called Men for Choice. The name is exactly what it is. We organize pro-choice men. And so part of that is pro-social in nature and really connecting guys around a progressive issue. And so that is sort of, I guess, one approach to sort of facilitating that pro-social behavior, but obviously has a very progressive slant. I'm kind of curious, with the Joe Rogans, the Jordan Petersons of the world, who people are sort of, captivated by and tapped into. Um, you talked about it a little bit, but what does that promotion of, pro-social behavior look like, or, what might it also look like if, there's room for growth there?
hmm So, I mean, I know your organization. I've seen I think y'all have a web page, right? I think that I've seen, and yeah, it's been spread around some circles that I'm in too. So that's great. And keep pushing it. Um, the thing that is interesting to me about this is like, when we think about when you, in that document that I shared, building bridges, right? So it talks about pro-social behavior for adolescents primarily, right? And kind of building in systems and projects and interventions that are going to help adolescents to build their kind of pro-social muscles and their skill sets in this context. And that being said, they over time, maybe they won't enact as much of the traditional masculine norms, or maybe they do, but they kind of balance it with like having more meaningful and interpersonal relationships, right? In the context of, uh, uh, you know, I'm trying to kind of like place the question in the space of like the Joe Rogan and thing and the podcast. I think a lot of it is modeling, right? And I think a lot of this has to do with, that dynamic of Theo Vaughn sharing his personal experience is very valuable for men. The problem is that there are times when you express your feelings and you express your emotions and you realize the guy on the other side, and this is women too, but the person on the other side of this conversation isn't ready. They're not ready to meet you. They're not ready to hear you. They're not ready to respond in a way that's thoughtful and meaningful. And you kind of walk away, you're discouraged and that's tough. Those are tough moments, right? So, one of the things that when we think about this as a pro-social kind of promotion, I do think it's modeling. And I don't think it's just modeling Theo telling the story, but that's why I pointed out all those different dynamics of what he had done in that situation. It's on television, and whether it's a podcast or whether it's regular TV show, we need to show people extending the arm and helping other people. But then we need to show the person who was helped, if it was me, coming back and saying, "Hey, man, I really appreciated you doing that. Thank you for doing that." That needs to be part of the dialogue, right? So that needs to be part of the dialogue, because you want to encourage more behavior like that, right? And then also by reinforcing, and I've been very conscious to do this in my own kind of personal circles, whether it's with men or women in my life, and just kind of the follow up is just so critical. But I think we need to show that in context, whether it's a social media platform or it's just kind of not just showing, oh, I did this great thing, but like the acknowledgement of the thing by the person who received it. I think that kind of promotes it because it makes it less scary to take the risk to do something for someone else, right? And I mean, that's just one kind of perspective on it. But I do feel like also like if we're going to the podcasts in this kind of, optimization approach to life, why aren't some of those titles like crushing friendship? You know, I'm kicking the shit out of friendship today. That's my title. Like, where's that title? You know, or like, why couldn't we have other like pro-social extremes, right? And bring it to that point. You know, I'm advocating the crap out of this topic today, right? So that kind of stuff is really like, how do we kind of optimize both ends of this or balance it out, right? I actually I was talking with somebody recently and I was saying, I'm going to make a podcast that's called Suboptimal, and I'm going to take all of their optimizations and I'm going to crank them down a little bit for a normal person like me, because I'm not an Olympic swimmer. I'm not some like mountain climber, but I'm just a guy, and it's just like, how do you kind of optimize this for everybody else, right? I'm not buying a $2,000 cold plunge. Get out of here with that, right? I'll turn the shower to cold for 30 seconds and see what happens. And that's about it. But I think there's ways to kind of like pull people in, model. I think there's opportunities there. And I think that it's, when you go into that building bridges document, one of the interventions I talk about in there is a thing called roots of empathy. And this is this really cool intervention that's been integrated into Canadian public schools. And it's typically targeting at elementary school students, and it's one of those things where they're talking to this. They bring the kids all on a rug in the middle of the room, and at the first day of this intervention, they bring in a mom with a brand new baby, and they sit on the floor with the baby, and the kids are all sitting around, and they ask the kids questions like, "Hey, what do you think the baby's thinking right now? Why did the baby cry? What do you think he's looking at? Do you think he can see you? Do you think he can hear us?" And what they're doing is they're asking a number of questions for the students in the room. And good moms do this too. I watch my wife do this all the time, right? And I'm not a good dad sometimes. But the thing is, like, good moms do this all the time. And they bring their kid to a point where they're starting to kind of like that psychology of the mind, right? So they're thinking about what somebody else is thinking about. What's important about that is it creates empathy. Right. So when you start to put yourself outside of yourself and you start thinking about other people's feelings and emotions, what you're doing is you're considering that baby something that's helpless, something that needs you, something that's going to be there to kind of like, is there because it needs your help. And they bring the baby back every couple of months. And so when the baby comes back the second time, maybe the clothes are different, right? It's not in the little onesie thing or wrapped up in a burrito. It's like one of those babies, it's getting bigger. Maybe it's crawling or something, or sitting up, or something's going on with it. And they point it out to the kids and they walk the kids through this whole dynamic of like, okay, so what's different about this baby? How is this baby different? What do you think? Oh, it made this noise. What did that noise mean? Why do you think it's crying right now? And they continue to kind of bring this back to the kids, and I know probably over time. But the thing is that it's just one of those interventions that is like kind of helping kids to kind of build their empathy, which builds their ability to connect with other people, and kind of builds their social support network. All right. So that's really critical. I think roots of empathy isn't the intervention for everything, but how do you kind of build those kind of feelings and kind of asking people to step outside of themselves to engage other people in their emotions? So I don't know. I kind of went around the way, but yeah, hopefully that's helpful.
So Dominic, I'm going to jump in at this point. It's beyond our hard stop, unfortunately. It's been a really great session. There's a lot more that I think a lot of us could have talked about, and obviously you're bringing up subjects that should be talked about a lot more, right? So thank you for being here. I thank the audience for their active participation. I thank Lynette Golding, who's giving us the clapping icon for recommending you. And with that, I turn it over to Hannah. I'm sorry, to Francis.
Yes, thank you so much. I know that we all really enjoyed that. And for anybody interested, we will have this posted later on our HAPI YouTube channel. I know that I'll be rewatching just to soak it all in again. So thank you so much.
Thank
Okay,
you.
take
My
care,
pleasure.
everyone.
Thank you.